This mini lecture is going to cover some bacterial infections that you'll commonly see in primary care. Usually both of these are caused by staph or streptococcus, including MRSA. And the first one we're going to go ahead and cover is cellulitis, which is an actual bacterial infection of the skin involving both the dermis as well as the subcutaneous fat. And these can be really detrimental to patients and even lead to death if not treated appropriately or in a timely manner. Most cases of cellulitis are caused by group A beta hemolytic strep or by staphylococcus for the gram-positive bacteria. Less commonly, you will see Haemophilus influenza, which is mainly seen in children and not as much in adults. Also, there are different bacteria that you will see for human bites as well as cat bites and dog bites and anything such as a seawater exposed injury. The typical lesion of cellulitis is a very wide diffuse area of redness on the skin that is warm and tender to palpation, and the patient may present with symptoms of fever, they may have chills, they may have body aches, and they'll probably feel like they're really sick, like they're people come in and say they're feverish. Cellulitis definitely can be a life-threatening event, which can lead to shock and as well as hypotension, as well as toxicity. So toxic shock syndrome and multiple organ failure resulting from both strep and staph have been reported, and we need to keep aware of that as we're treating these patients. There are some severe cases of cellulitis, such as necrotizing fasciitis, that need to be treated with surgical debridement, and that would be in addition to parenteral antibiotics to prevent the spread of that rapid tissue destruction. The hallmark of this infection is that it's got a rapid progression. And so they also have known to have this called the flesh-eating bacteria. So loss of life or limb is a very high potential complication with necrotizing fasciitis. When you see the early phases of that infection, the lesion appears as a bright red color with swelling, and it progresses to like a purple color, and then it turns to a black color. So gangrene can really set in pretty quickly in those type of patients. When you're thinking about a patient that has periorbital cellulitis, there's this is also a potentially life-threatening form that should be treated as an emergency. The typical patient would be either a young child with swelling and edema over the affected periorbital area, but also adults can have this if they've had something that bit them near the eye or had an injury to the eye. The edema can be severe enough so that the entire affected side of the face is puffy, and they may have difficulty with certain eye movements as far as pain goes. And because those extraocular muscles are involved, so it's very difficult sometimes with that pain to move their eyes from right to left or up and down. These patients might get high fever, they may get tachycardia, they may have some mental status changes and some other systemic changes. So when you're examining them, the involved eye will lose the ability to move into those certain quadrants, and they'll have some abnormal exams of the cranial nerves 3, 4, and 6 because of the extraocular movements. The other infection that we may see in practice is erysipelas, and erysipelas is a streptococcal infection of the superficial layers of the skin that does not involve subcutaneous layers, and it's unlike a more typical cellulitis. The older name for this used to be called St. Anthony's fire, and despite the superficial nature of this infection, it should not be taken lightly because it can be fatal if it's not treated appropriately and promptly, especially in very young or in the elderly. The skin with this takes on an orange peel texture, which is known as peau d'orange, and so that's one of the key features of this. Most cases are caused by group A beta hemolytic strep, and it sometimes can be seen after someone's had a severe strep throat. The most common sites of involvement you're going to see with these patients are in the face, especially the cheeks and the lower legs. Most of them have systemic symptoms similar to the other cellulitis infections with the high fever, the body aches, and the chills. If they have this on the face, it appears as a bright red lesion by the nose, and that can spread rapidly within a few hours to days. And then it enlarges into a shiny, bright red indurated plaque that develops, and it's very warm to touch. It has very distinct borders, and this is very opposite of just a plain cellulitis because that has more of a diffuse, flat border to it. And the skin gets real shiny because of the swelling from the infection. So both of the cellulitis as well as the erysipelas both become complicated, or they could be uncomplicated. So how are we going to go ahead and treat these patients? Well, treatment of cellulitis should be taken into consideration, from several factors. So we have to think about the severity of the infection, the site of the infection, what could be the underlying problem, and is there virulence of the pathogen? And patients with diabetes are known to have this higher incidence of complications from the skin infections due to those chronic high levels of glucose. Also, patients undergoing, long-term treatment with steroids or chemo who are immunodepressed, as well as somebody who's had some surgical procedures. So these are all patients that can be at risk. When someone has a human bite, those wounds are known to have a higher rate of infection because of the large amount of anaerobic bacteria that's present in the mouth. And because of increased vascularity, the face and the neck are less likely to become infected than the hands and the feet. Cat bites, maybe 30 to 50%, are more likely to become infected with Pasteurella multocida than human bites. So human bites are nasty, and cat bites are not much better. They're right behind them. If you think about, especially if you live near the coast or you live near water, you have to think about any injury that occurs in salty or brackish water that has the potential for infection with a Vibrio species of bacteria. And then the periorbital cellulitis is also, as I said, life-threatening and needs to be looked at real carefully and treated appropriately. So although strep and staph are the major causes of these skin infections, you still have to think about that etiology and get a culture if you are able to obtain that culture. So when we think about the treatment for these, the good choices for an uncomplicated case, not associated with a human animal bite or human or an animal bite, would be the cloxacillin or the cephaloxin for 10 to 14 days. Also, we're using penicillin, such as the augmentins, the cephalosporins, the erythromycins. All of these are really good for treating these patients specifically. IV antibiotics, you'll need to admit them to the hospital for that if that's what you need to do. And many times, if the condition is very severe, that's going to need to be done right away. For oral therapy, you can, if you suspect Haemophilus influenza, then you can use Ceftin for that. Azithromycin or chlorantraniliprole is preferred as a macrolide over the erythromycin if they're allergic to penicillin. And then for the patients who are not allergic to penicillin, as I said, Augmentin for 2 weeks is usually a pretty good option. And if it is a human bite or a cat bite, that is your drug of choice, is Augmentin. So many times also we use topical antibiotics such as Bactroban, and this is a really great antibiotic that you can use because it really helps to, if it's more of a superficial type wound, it really helps to clear it up pretty well. And it's one of the antibiotics that is used most frequently by dermatologists for when they've done some surgical procedures on patients and then they've closed them up. This is a really good option for those patients. And this is a picture of a furuncle, and you can see the pustule developing here. And this is most likely a staphylococci organism here. This is a really good photo of someone who has a soft tissue cellulitis, most likely MRSA, and how the leg gets very erythemic and swollen and tight and taut and shiny. So this is somebody who probably needs to be admitted in the hospital for IV antibiotic treatment. So the other infection we're thinking about is the methicillin-resistant Staph aureus or MRSA. And about one half of all of the skin and soft tissue infections are related to MRSA. The transmission of MRSA is via direct skin to skin contact or contact with a contaminated surface or items. And the outbreak of these skin abscesses caused by MRSA often occur in environments where there's some type of a close personal contact. So it could be with families or athletes sharing space or equipment, somebody who's been exposed to another infected person or then contaminated those items. So there's a lot of different things that can lead to this. This resistance to methicillin is due to the presence of the MEC gene in the bacteria, which alters the site at which the methicillin binds to kill the organism. So it's not able to bind to the bacteria. And these infections caused by MRSA are the same as other staph because the organism itself is not any more virulent than the usual type of Staph aureus. But the problem arises when the treatment is limited. MRSA occurs mostly in the hospitals and in institutions. And although the occurrence of MRSA in otherwise healthy adults has become more increasingly common in many parts of the United States, hospitals still are considered the most opportunistic pathogen. It can cause infection in the healthy young person with no type of predisposing comorbidities. And community-associated MRSA was initially described by IV drug users back in the 80s and was believed to be a consequence of them using frequent use of oral antibiotics to prevent skin infections from where they may have got infected or presumed they were going to get infected at an injection site. But then for most of the 90s, it was limited to the Native Americans and prison inmates and the homeless and the IV drug users. And by the late 90s into the 2000s, that pattern had really shifted significantly to young adults in the mainstream society frequently affected. So prior to that time, the contagion among otherwise healthy persons was really not documented. The risk factors for skin infection are any disruption of that cutaneous barrier. For example, skin trauma, a fungal infection maybe that has led to some type of a skin fissure, as well as nasal carriage, nasal passages, and oropharyngeal and rectal passages being infected. So a lot of patients will present thinking maybe they had gotten bit by a spider or some type of bug outside, and where indeed it may not have been that problem, or it may have been that problem. Several studies have been done to precisely identify the rapidly changing risk factors for the development of MRSA, but at the present time, there is an agreement that it should be considered a likely cause of infection in the presence of any patient that reports a recent treatment with an antibiotic, anybody that it is known to be colonized, has a history of being in the hospital recently, and resides in some type of a geographical area where there is a high prevalence of this. So how are we going to go ahead and treat this? Well, it's really going to depend. You have a couple options. Option one would be incision and drainage alone, which is a treatment option that reflects just a controversial role of empiric antibiotic therapy in the treatment of uncomplicated skin and soft tissue infections. Surgical drainage does remain the most important intervention if they have a suppurative skin abscess. And also, antibiotics have not been shown to really improve the outcome in patients with an uncomplicated abscess compared with incision and drainage alone. So this general principle holds true for a MRSA abscess as well as for skin infections that are caused by other things. So antibiotics are usually not needed in otherwise healthy adults or individuals with an uncomplicated abscess and no coexisting medical conditions and no systemic signs of infection. So you have to think about what is going on with the patient and what their history is before you're treating them. The antibiotic, if you do use an antibiotic, for MRSA, the trimethoprim, sulfamethoxazole, the Bactrim or the Septra is your drug of choice. And it can be, given in a suspension form. Children can take it, adults can take it, and you usually treat them for 5 to 7 days. Your other option would be a minocycline if they cannot take, or a doxycycline even, if they cannot take the Bactrim. And the next thing we're going to look at is folliculitis. And folliculitis is a common infection that is seen with arising from the hair follicles. It's usually caused by the invasion of the follicular wall by bacteria, and the most common organism that does invade this area is Staph aureus. The manifestations usually it just kind of depends because it varies with the depth of the bacteria. Abscesses can form, ferrucles can form, carbuncles can form. So it just really is going to depend on the size and the depth. So with inflamed hair follicles, there's pustules with a erythematous base, and you could see by the picture that I had just put there, they could be superficial, they can be deep, and they can affect anywhere that there are hairs. A lot of men get them on their face, a lot of women get them under their axilla when from shaving. So the most common places are those areas, and also in the central trunk. Staph aureus, as I said, is the most common infection. There also could be chemical irritation from cosmetics or even mechanical irritation from tight clothing. Women who have a tendency to wear really tight jeans or tight pants have a tendency to get these in the groin area because of the tightness of the clothes against the legs. Usually when you get these, you don't need to be culturing the patient because it's not really going to give you much information. You just could go ahead and treat them accordingly. And when you're going to do an exam with these patients, you want to look for the location as well as the appearance. And you want to make sure that the lesions are typical looking and that they're superficial and tender. And if they're not, then you may need to consider other treatment options. Treatment usually is in using the Bactroban cream, which I told you works very, very well. You just put a small amount 3 times a day to the affected area for 7 to 10 days. You can also use Altabac, which is supplied in a 5, a 10, a 15-gram tube. So if you've got larger areas, it's the first of a new class of antibacterial agents derived from the fermentation process of fungi. The mechanism of action is through interference with the bacterial protein synthesis, and it can be effective for treatment of MRSA, but the manufacturer has not been given the approval to use that claim by the FDA at this time. But it does work very well in folliculitis at this time. And clindamycin solution is another one, the Cleocin T, and you can use that twice a day for 7 to 10 days. You don't really need to see the patients back and follow up unless they're not responding to treatment. So this is pretty easy to treat, and it's pretty easy at being resolved. Another condition that's possible to see in primary care is called dermatitis medicamentosa, or drug eruption. And this refers to any eruption to the action of a drug which reaches the skin by way of the bloodstream. And the term really does not apply to any local reaction which may occur as a result of the direct contact with the skin from the outside. And it is present in the most varied clinical manifestations. So you may see erythema, you may see papules, you may see bullae, depending on what drug they've taken. It affects really of all ages and all races and both sexes, but among adults, women are more likely than men to develop these, and they tend to occur more frequently in the elderly population. So if someone has a weakened immune system because of their illness, or they have an infection, or they're taking 3 or more medications a day, they have a potential to get this. Although any medication can cause the rash, the most common types of medication that cause a dermatitis medicamentosa are antibiotics, as well as the non-anti-inflammatory medications such as the NSAIDs, pain medications, anticonvulsants, chemo drugs, psychotropic medications, iodine, so many different medications. They do feel that this is an IgE or a T cell mediated response, and they lean now towards the more non immunological response, which is the most common. So they develop when the specific antibody or the sensitivity lymphocytes to a drug develops. So usually that sensitivity starts within 4 to 5 days of that initial exposure. And as I said, the maculopapular rash occurs. They get that itching, they get that burning sensation to them, and it may look like pink to red bumps. They could get hives or blisters. They could get some red patches, and on occasion they may get fever, but that's very rare to see that happen. Onset after they've been exposed is about 7 to 10 days. So they might start developing that mediated response within 4 to 5 days, but you're really going to see it pop out in 7 to 10 days. And it even can occur after the drug has finished. So I've even seen patients where they've been off the medication for 7 to 10 days and all of a sudden they erupt. Then it can last up to 1 to 2 weeks. If they have that urticarial, it is highly suggestive of a drug reaction. Most drug reactions resolve when the drugs are stopped and they don't need really any more therapy to them. You can treat them with cool compresses. You can do bed rest. You can give them anything to relieve the itching, such as the Aveeno, which works very well. Any type of a topical antihistamine gel will help them, as well as any type of astringent lotions or, pastes are suitable. The antihistamine drugs may relieve itching, but with the exception of the urticarial reactions, they do not benefit the eruption greatly. And it must be remembered that the eruptions have been attributed with some good reason to the antihistamine preparations themselves. Severe symptoms in the case of these patients would be collapse, dehydration, blood dyscrasias. I have never seen that in practice, but it does have the potential to help to happen. Oral corticosteroids, if they really are bad, that you need to give them something with to really blast this out of them, and the topicals, steroids, but the documentation of those really is lacking. So they don't effectively work to give the topical, but the oral do.